Hello, good evening. Welcome to my IVF Answers and the European Fertility Society. We are back once again with our special guest, Dr. Harry Karpouzis is with us. Hello, Dr. Harry. Welcome back. I hope you had I'm sure, long day, busy day, but I'm happy to see you. How are you? How have you been?
I'm fine, Caroline. Nice to see you again. Hello to everybody. It was a busy day, but it's okay. We can talk. It's a very interesting topic.
Definitely. And today we will talk about hysteroscopy for pre-IVF evaluation. So this is definitely, I know that this is one of those subjects that you really enjoy and like, right? This is another one of those, I think.
Nice.
So,
Apart from the IVF part, I'm a minimal access surgeon as well. So it was
okay.
like my
Yeah.
first love. So
Okay.
Yeah, I like hysteroscopies generally, and it's an interesting topic on when we need to do them, when not, and what they offer actually. So we can talk about it.
Definitely. And I'm sure you will have lots of questions as always. So please put those in the chat. You can do it right now during the presentation afterwards. And I'm sure Dr. Har will be happy to simply discuss it. I'm sure it's going to be a great session as always. So please don't forget to do that. And of course, remember it's all anonymous. So feel free to share any details you would like to share. And as I mentioned, we will start with our presentation and then we will go for your questions. So don't hesitate. It's all being recorded as well, so you will have a chance to rewatch it as well. And just let me remind everyone, Dr. Harry Karpouzis is the scientific director and founder of Pelargos IVF in Athens. And so this is not our first event, and I'm really looking forward to listen to what you will discuss today, of course. And yeah, I think we can go ahead with the presentation. Ready?
Sure.
Perfect. Let's go for it then. Thank you.
Okay. Hello, everybody. Thanks for being here. We will talk today about the diagnostic advances in hysteroscopy for people that are planning to go for IVF. Let's say general things about, first of all, what is a hysteroscopy. Hysteroscopy is a surgical procedure, a minor surgical procedure, minimal invasive procedure, through which we put a camera inside the opening of the womb, inside the cervix and the cervical canal, and we have a look inside the cavity, the endometrium of the uterus, of the womb, the lining of the womb, under direct vision with the help of a camera. A big advantage of the hysteroscopy is that apart from a diagnostic procedure, it can be a therapeutic procedure at the same time. It means that we can also treat. Hysteroscopies can be done as an outpatient procedure, which means without a sedation, without an anesthesia, or with an anesthesia, especially in cases that at the same time we need to remove a submucosal fibroid, a polyp, a septum, or anything like that. So we said that we have the diagnostic and the operative hysteroscopy. When we talk about the operative hysteroscopy, through that we can remove a polyp with scissors. We can resect a fibroid with energy, or even with scissors sometimes, or mechanical with special instruments that we take the fibroids out piece by piece. All these are inside the lining of the womb, and we are talking about fibroids that are submucosal, which means that they are inside the lining of the womb. So if we have a fibroid which is outside the cavity, obviously we will not be able to remove that with a hysteroscopy. Some women that have a septum from birth, for example, we can treat it and we can separate that so that the womb will be bigger to implant an embryo. Scar tissue, what we call Asherman syndrome, from previous terminations, from previous infections, from previous surgeries. Sometimes we have scar tissue inside which might be causing a thin endometrium, a thin lining of the womb. So in cases like that, we can treat it at the same time with a hysteroscopy. Many times, at the time of a diagnostic hysteroscopy, we can combine it with endometrial scratching. We will talk about that later. And also, we can combine the hysteroscopy with some diagnostic tests that have to do with the immunology, tests about chronic infection, endometriosis, and about the implantation window. Let's go a bit through the research, the latest research. A recent meta-analysis, which means many studies that have been analyzed together, randomized studies, have showed that when the hysteroscopy is done in women with previous failures of implantation, the hysteroscopy can improve the live birth rate and the clinical pregnancy rate. When a hysteroscopy is done for everybody, for even people that do not have a relevant history of previous recurrent implantation failures, the data is mixed. And actually, it doesn't show a conclusive evidence that they can really help. So this is a big question generally on if everybody that goes for IVF needs to do hysteroscopy. The answer coming from the research is that not really. We cannot prove that. Many things, though, need to be balanced on that. Many things need to be balanced that if something rare is lost, this means that an embryo transfer might fail, and then it's the cost as well. But the cost needs to be balanced against missing something and then having a repeat embryo transfer that has additional cost. So everything is a balance. But as a general rule, no is the answer. A hysteroscopy does not need to be done for everybody necessarily. Now, chronic endometritis. Chronic endometritis is the chronic infection inside the lining of the womb, inside the endometrium, and can be associated with recurrent implantation failures. It can be associated with unexplained subfertility. It can be associated with recurrent miscarriages. The golden standard of diagnosis of that is hysteroscopy. Many times, endometritis does not give symptoms. A person might not know if has endometritis or not, chronic infection, and the only way to find out is by inspecting the cavity and finding signs of a chronic infection. The question, why not to do an HSG or a Hysteroscopy that doesn't need a sedation, it's not so intrusive? The answer is that the role is different. An HSG is mainly used to check about the tubes and the patency of the tubes. It can also check about the endometrium, but not as good as a hysteroscopy, which is under direct vision with a camera. The same thing with a Hysteroscopy. So if we want to identify sometimes mild scar tissue or mild septums or chronic endometritis, these are things that you cannot find with an ultrasound, with an HSG or a Hysteroscopy. Technology. I mean, nowadays we have smaller cameras, smaller hysteroscopes. We have flexible hysteroscopes that we can do them as an outpatient procedure with less discomfort. We have 3D imaging. We have high definition cameras. All these have been for a long time. One advancement that might have a lot of future, actually, it's implementing the AI together with the hysteroscopy. Sometimes it is very difficult to identify lesions even under direct vision. I mean, endometritis, it is not easy to identify, and we will go there in the next slides. A person that doesn't have a reproductive medicine knowledge might be a very good minimal surgeon, but not being able to identify all the signs of endometritis. And even if you have experience on that, there are so many different signs and there are so many different ways of presenting inside the endometrium that sometimes might be missed. So minimal lesions of endometritis, subtle signs, minimal scar tissues, to take targeted biopsies at the time of a hysteroscopy from exactly the point that we need to take it. All these things might be improved in the future through the AI, and already we have some data sets that have been implemented in some of the units. Finally, I mean, in our unit, and sometimes we combine the hysteroscopy with stem cells treatment as well for people with persistent, resistant Asherman syndrome and persistent thin endometrium that we treated surgically and it is not improving. As a last resort treatment, we have some good results actually by injecting the stem cells under the endometrium, under the lining of the womb, in order to achieve a better thickness. So this can be associated as well together with a hysteroscopy. Now, clinical benefits. As we said before, we can take targeted biopsies from specific points inside the cavity. We can identify the chronic endometritis, which is a chronic infection. We can remove polyps. And polyps, we know that even if they are small, they can reduce the chances of implantation and they can increase the chances of miscarriage. We can remove a fibroid, a submucosal fibroid. We can do that with energy, bipolar energy, mechanical, with a special machine which is called myosure. We can treat adhesions, we can treat septums with scissors, with energy. We can do everything with a hysteroscopy, anything that happens inside the lining of the womb. We can combine it with endometrial scratching, as we've said before, and also in people that have difficult embryo transfers before, that it is not easy to pass the catheter, that have previous loop LEDs treatments because of HPV and anomalies in the smear test. All these, or false passages because of previous surgeries inside, all this might make an embryo transfer very difficult. And you know, to do a hysteroscopy can show you also the cervical canal and can show you the way of passing the catheter. So you can use it as a very nice way of doing a mock transfer as well. And of course, we can investigate about thin endometrium with hysteroscopies. Now, regarding endometrial scratching was very in fashion a few years ago. It still is, but we need to clarify a few things. A systematic review in 2023 with a very big sample of people showed that endometrial scratching during the hysteroscopy and before the embryo transfer can improve the live birth rate in women with recurrent implantation failures. It doesn't show any difference in the miscarriages rate. And when we did another randomized study in about 1,000 patients, in people that have first-time IVF and they don't have a history of recurrent implantation failures, endometrial scratching does not offer anything. Now, is there an association between endometrial scratching and immunology? In a way, yes. And there are some reports and some studies by a French immunologist who is called Lede that shows actually that the local inflammation that is caused by the local injury of the endometrium can cause the secretion of some cytosines like interleukin 15, like tumor necrosis factor. And all this can cause uterine natural killer cells to be mobilized. And we know, for example, when we do specific tests, that in some women, the problem is not the over activation of the uterine natural killer cells. The problem is the opposite, is that we don't have enough mobilization of them. So in this category of patients that can be found out with some specific tests, in women that have recurrent implantation failures and recurrent miscarriages, the endometrial scratching, when it is combined with a hysteroscopy, can show an improvement. When are we doing it? We are doing it in the luteal phase of the previous cycle. And why together with a hysteroscopy? I mean, it can be done without a hysteroscopy as well, but together with a hysteroscopy, when especially we have recurrent implantation failures, we get a direct assessment of the cavity. We treat at the same time. We combine these two procedures so that it's not needed later on to do a second procedure like a hysteroscopy. And we take targeted scratching, okay? Now, regarding endometritis, as I said before, it's the golden standard of diagnosis. I explained before why it is important, the person that is doing the hysteroscopy, to have reproductive medicine knowledge as well, to know to identify the signs of endometritis. It is not easy at all. And I will show you some slides later on to understand how difficult it can be. And also to take targeted biopsies, because if we don't take a targeted biopsy, it might come back as normal and might be an endometritis in another place inside the womb. When you take blind, you are not sure that you take the right sample. I mean, we explained what is the chronic endometritis. Sometimes it doesn't come with symptoms, and many times it is associated with recurrent pregnancy failures and recurrent implantation failures and unexplained subfertility. The signs of endometritis are very difficult and can vary a lot. It can show in the hysteroscopy an image of micropolyps. It can show a thickened and pale white endometrium. It can show red spots inside. It can show something which is called, with a lot of imagination, like a strawberry aspect, which means red and white spots. The combination of all this gives you an accuracy of endometritis of about 93%. But many times we don't have all these things. We might have one or two of them. And it is not easy to understand in a hysteroscopy that we have a chronic infection. So you need to take a targeted biopsy, identify where you need to take the biopsy from, and also these biopsies, can it be seen in a histology? It can be seen sometimes in a histology when we do a special test which is called CD138. But nowadays we have very good tests which are molecular tests, NGS tests like ALICE, like EMA, like endometrium, depending on what you are using, which actually shows exactly what we have inside, what is the cause of the endometritis. Is it E. coli? Is it ureoplasma? Is it mycoplasma? Is it herpes virus? Is it something else? So then you can give antibiotics for the specific treatment. And you can see here how many different presentations you might have inside the cavity. I mean, if you see the first picture over here, I mean, this is the normal endometrium, and then this is the endometritis. But the endometritis can present in a completely different way as well, like the one in the second slide, or can present in a different way like the one on the third slide. All these things are endometritis. You need to identify it, first of all, and you need to take specific biopsies. And you see other presentations here. These are the micropolyps. This is the pale endometrium that I was talking before. In the first picture, it is like the strawberry aspect. Conclusions to finish, and then you can ask any questions that you have. I mean, the hysteroscopy improves the outcomes before an IVF in selected patients and not in all the patients. Usually in patients with recurrent implantation failures, it does have a benefit, and we need to do it for sure. It needs to be done by doctors with experience in minimal access surgery, but reproductive medicine as well. It can be combined with emerging technologies like molecular tests, like stem cells, like an AI, etc. It's the golden standard to see and identify endometritis. It can be therapeutic and diagnostic together. It is ideal to combine it with testing like ERA test, which shows the implantation window, like IMAP test, which shows about immunology, like ALICE and EMA test, which shows about the microbiome and about endometritis. It is superior diagnostically than ultrasound, HSG, and HICOS in identifying few things, and also allows you to take not blind, but targeted biopsies if you need to take biopsies.
Brilliant as always. Thank you so much for introducing us to hysteroscopy, how it works, how it can help, and of course today we are definitely here for your questions. And I do see lots of questions are actually right here. I don't know if you had a chance to look, but we did receive quite a few questions already. I don't want to keep you waiting any longer. So the first question is from Elena here. I will show it to you. There are some details as well. I did 3 embryo transfers. None was PGT tested as it is not allowed. Graded 5 AA but failed implantation. Again, 5 AA failed implantation, and 3 BC chemical pregnancy. Could there be underlying other issues besides for chromosomal abnormalities leading to recurrent implantation failure that a hysteroscopy could identify and solve?
Yeah, I mean, it could be. I don't know your age as well.
Yeah.
How old are you? I mean, but 2 of the embryos that you've put back were very good quality embryos. So they have good chances of being chromosomically normal. especially if you are in a good age, they have failed. So by definition, you are a recurrent implantation failure patient right now. So, I mean, first,
35.
you
Yeah,
are in a
that's the
good age.
age.
So first, I mean, if you decide to proceed again, you drop into the category now of recurrent implantation failures. So, I mean, PGTA needs to be done for you, okay? Because you have 3 failures before, and 2 of them with very good embryos. But if you create a chromosomically normal embryo and you know that the embryo is okay, before you put it back, it would be reasonable of checking other things as well. And one of these things is hysteroscopy to make sure that you are not missing something like a chronic infection, like a small degree of scar tissue, like anything else. So hysteroscopy is one of the things that, yes, I would advise of doing before you transfer another embryo.
Okay. Again, thank you for that. Yeah, Elena, I would like to thank you as well. She just messaged here. So I hope that helped. If there's any other follow-ups, you know what to do. And let me just go to the next question. As I mentioned, plenty of those. And I would like you to have a look again, quite a lot of details. So endometrial thickness progress, given that my endometrial thickness has remained at 5.2 millimeters despite the medication, can you explain what factors might be preventing further growth? Are there specific reasons why my endometrium is not thickening as expected, even though I've been following the prescribed medication, lifestyle recommendations carefully?
I know, Zara. I have answered to her in an email as well.
Okay.
Um, so I will answer the same, that I don't know. She needs a hysteroscopy to find out if the thickness is not achieved. Okay, so when you take a maximum dose of estrogen and you take it correctly, and the endometrium is not getting as thick as it should be, then you need to investigate. So you need to put a camera inside to have a look, to find if there is any problem at all, and to treat this problem so that you can have better thickness later on.
Right. Okay. There are actually quite a few more questions from Zahara. So I can show you the next one. Perhaps we can see this one. Chances of improvement before transfer, with just a few days remaining. Do you believe there is enough time for my endometrial thickness to improve? Is it realistic to expect the necessary change in a short time? Or would you recommend postponing the transfer?
Well, listen, this is a question actually which is good generally. How many days of estrogen someone can take before we start the progesterone? Most of the studies show that these days need to be between 12 to 18 days of estrogen before we start the progesterone. We cannot keep prolonging and prolonging and prolonging the estrogen because this might affect the implantation window. And also, if the thickness of the endometrium is not thick enough with a high dose of estrogen in like a period of time of 18 days, we don't expect it to grow a lot after that. We need to investigate what is happening. So, I mean, when you have checked on like the 12th day of estrogen, you can keep pushing, you can increase the doses, you can reach it to the maximum, you can give it a bit of more time, but you will reach finally a stage on which, if it is not achieved the right thickness, instead of compromising your embryos, you might be better to cancel and check to see what is happening.
Okay. Again, thank you so much for yet another advice here. Of course, I do see some more questions. So let me go to another patient. Okay, we will go back with those, but I just want to make sure that we can. Yeah, sorry. Karen would like to ask you what test in UK can confirm CD138 and endometritis? Hysteroscopy booked, but worried it may be missed. Last one, clear but thin lining. Anything you can advise here?
Yeah, I mean, endometritis, it is something that, first of all, you need to see it, okay, in the camera. Now, if you take a biopsy and you send a proper histology, a normal histology, maybe in this normal histology, the endometritis will not be shown. It needs a specific typing of histology in which we use the CD138, and when this is identified and we see plasma cells, this shows signs and suspicion of endometritis. But the most accurate way of doing it to also find out not generally endometritis, but also what is the cause of endometritis. If it is ureoplasma, if it is mycoplasma, if it is E. coli, if it is something else. There are tests right now, like molecular tests, NGS tests, like ALICE, EMA test, or endometriome, or they have several names, which actually they show as well the cause, the specific cause, and they can tell you what antibiotics you need to use. Okay, because if you don't know what is the cause, then you go into a scheme of triple antibiotics to say, okay, I will cover everything. But when you know what is the cause, you target specifically the cause and you treat it.
Okay. I think that again was helpful for you. I will go to the follow-up from Zahara. Okay, so if the cycle is cancer or delayed, how would my treatment plan be adjusted for the next cycle? Will the medications or protocol change?
Okay, I'll answer that as well. I don't know. I mean, if we do a hysteroscopy and we see chronic infection, you will take antibiotics. If we see a deranged microbiome, you might need probiotics as well. If we see scar tissue inside the hysteroscopy, we will treat it because we have a reason. If nothing works and the endometrium keeps being thin, we have some ways of increasing the endometrium, like PRP or stem cells that we talked before.
Okay. Thank you again. And I will go to the question from Karen, follow up from Karen. So I will go to the very end of the question, sorry, so we can keep it together. Can you just have Emma Alice, I think, instead of hysteroscopy to find endometritis? Is CD138 the same as endometritis?
No, this is something that CD138 is something that we identify to show infection, to show inflammation, to show possibility and big chance of endometritis. Okay, Alice and Emma tests are tests that show the microbiome and causes of chronic infection inside the endometrium. It can be done as an outpatient procedure without a hysteroscopy as well. Yes. But when you do it blindly, you might miss a few things because you don't know exactly where you will take the sample from. You might take the sample from areas that do not show the chronic infection. So it is doable, but it is always better, if possible, to do it together with a hysteroscopy because at the same time, it's not only about endometritis. You might see other things as well that you can treat at the same time, like a small polyp or some scar tissue or anything else. And also you can take targeted biopsies with a camera. When you do it as an outpatient, you just put a pipelle inside and you take a scraping. Most of the times it shows something, but it will not be targeted.
Okay. Brilliant. Thank you so much. Now I will go for the next question. Sophia has added the question. Let me just show you once again more details here. 5 miscarriages through IVF, 1 ectopic and 1 tube removed, 5 failed transfers, including the 2 IVF. And my Swedish doctor doesn't want to do hysteroscopy with the motivation it can be damaging. I'm sure it's just a cost question on their end. What should I say to convince him that we need it? Any other recommendations? PGTA not legal in Sweden, but we're considering going abroad. Yeah.
Okay. I mean, it's not only hysteroscopy. I mean, hysteroscopy is something that my personal opinion is that you need to do it. But I mean, 5 miscarriages is recurrent miscarriages in a big degree. Ectopic is something different. Failed transfers, it's recurrent implantation failures as well. So this needs a thorough investigation. First of all, I mean, it would be a very good idea after all this history of knowing the chromosomes of the embryo before you put it back. Because if you keep putting embryos that you don't know the chromosomes of, it might fail again, and then you will not know exactly what is the reason. You might investigate everything else, but in the end, it might be the embryo. And if you manage to achieve a chromosomically normal embryo, then all this needs thorough testing. I mean, you need to investigate about thrombophilia, blood clotting disorders. You need to investigate with a hysteroscopy about endometritis and things like that. I don't see how a hysteroscopy can be damaging. It's a very straightforward procedure in the right hands. Day
Mhm.
case that you go home the same day. You can combine it with some tests as well that have to do with immunology, because you need to check about these things as well. Five miscarriages might need some steroids, might need some intralipids, some placanil, some additional progesterone, depending on what exactly is the case.
Mhm. Okay. Again, thank you. Let me just go for the next question that we have, and this is here. For a patient whose blood work tests are normal, hormonal assay are normal, endoscopically no issues, what can you say would be the possible cause of miscarriage? With this information, you're able to tell us.
I mean, the most common reason of miscarriages is chromosomes. So I don't know your age. I mean,
Mm,
you keep in mind that in the age of 40 to 42, sometimes the risk of miscarriage might reach 30%. And in the age of 44, the risk of miscarriage, even in a spontaneous pregnancy, can reach about 50%. And the reason is chromosomes. So that's the most common reason. I mean,
mhm,
if you have done blood clotting and thrombophilias and things like that, okay, you rule out these things. If you have done a hysteroscopy and you haven't seen anything that can cause a miscarriage, that's good. Okay, you rule out that. I don't know if you have checked also about immunology, which is a very important thing that can cause miscarriages in some cases. There are relevant tests, either blood tests or endometrial tests, which we prefer usually, I mean, at least at Pelargos IVF, that you can check the local immunity, the natural killer cells, other factors, cytosines, and adjust your treatment and personalize your treatment according to your problem.
okay, again, I think that was useful. Let me know if you have any other questions. I will now go to the questions from Zahara, okay? As this is, I think, another follow-up here. So just give me a second. It's right here. So with just a few days remaining, do you believe there is enough time for my endometrial thickness to improve significantly? Is it realistic to expect the necessary change in such a short time? Or would you recommend postponing?
I think I've answered this question before, Caroline.
Sorry, I might have missed this then because this is just a new message, so that might be the case. Sure. Yeah, I think we did. Apologies. Let me go to the next question then. We've got, yeah, sorry. There's one more from Karen. I think I missed that one. That's the issue. I had fertility testing for microbiome, was period blood and swab, yeah, bloods and swabs. This came clear. I'm told similar or better than Emma and Alice. Maybe I still need Emma, Alice. I don't know. I understood fertility would cover all. Okay.
It's a nice test. We are planning of introducing as well. It's a nice test. More or less, they are doing the
Mm-hmm.
same job. Emma and Alice, I mean, are from the inside of the endometrium usually. The microbiome test, it's with blood from the period, but it has some significant, evidence behind it. So it is a nice test. I mean, if it has come back negative, I mean, what I usually say is that when you go and you choose a doctor that proposes a test or you choose a specific test, trust the test. Okay, I cannot tell you that hemolysis is better than fertility or not. They work in a bit of different way. Hemolysis is a test that has a longer time in the market, but I know about fertility and I know that it can show things sometimes even more thoroughly than Emma and Alice. All of them are doing more or less the same job, identifying the same things with a different way. I don't know. I wouldn't. If you have done the fertility, I wouldn't really repeat it in order to find something. Maybe the problem is hidden somewhere else.
Okay. All right. Again, thank you. And let us know if there's anything else. Yeah, thank you so much indeed. And let me just go to another question from Emil. Can endometritis be treated based on hysteroscopic images without pathological examination?
Yes, if you are sure and know how to identify, you can. You don't really need to have like an NGS test. NGS will confirm the cause of the endometritis, because if you don't do that, then okay, you say endometritis, but you don't know what is the cause of the endometritis. So you might need to take, a triple scheme of antibiotics to cover everything. Or you might need to do in some units, even though there is not a lot of evidence behind it, the endometrial washing and things like that. So that's the only benefit of taking targeted biopsies. But sometimes it is pretty obvious that you have inside endometritis, so you can trust the doctor as far as he knows how to interpret it.
Okay, thank you. We will change the topic a bit, but perhaps you can tell us, can acupuncture be beneficial? If yes, at what stage is it recommended, before egg retrieval or before transfer? And do you also perform it at Pelargos IVF?
Yeah, we have a very good acupuncturist at Pelargos IVF. He's from San Diego in the US. He's quite experienced in the field.
Yeah.
So we use it. We have seen some good results. I don't know exactly. I mean, I know, but I'm not convinced exactly on how it works. It might work even as a stress relief, either with a placebo effect, maybe with people that know how to do by creating a local inflammation or any other reasons. It is not proved, but there is research that shows that it can improve. It can improve sometimes the thickness of the endometrium, sometimes the chances of implantation, sometimes maybe the number of the eggs. By any means, it will not cause you harm. And especially if you go through this procedure as a stressful person, etc., you don't have anything to lose about combining it as an adjuvant therapy. It's not to replace the IVF, but it is to be used sometimes together with IVF, possibly to help.
Okay, I think that's fair to say that it's helpful, although it's I think that there's still like evidence lacking, right? There's no real evidence to prove that it actually works this way and that way.
There is no conclusive evidence, but there are some good studies actually that have showed some improvement with ways and mechanisms that we cannot always clarify.
Yeah, that's true. All right, I will show you two questions from Zahra. Okay, so why has the dose of, I'm not familiar with that one, sorry, been increased to the maximum, and how does this increased dosage affect endometrial growth? And the second is, are there any concerns with continuing at this higher dose? Can significant improvement be expected in the coming days? You kind of
Because if the endometrium is not getting thicker with a good dose and it takes it to increase it a bit more, we can increase it a bit more to see if it will help or not. Because otherwise we will not know. So that's why we have increased it. And
sorry.
no, there are no concerns.
Yeah, I think that is clear. Again, thank you so much, and let us know if there's anything else here. And I will show you again quite a long question from Elena. And would you recommend hysteroscopy for a woman who has the following: 43 and a half, never miscarried, never tried to get pregnant, never tried fertility treatment yet, history of treated chlamydia, 20 years old, cell changes with colonization surgery in cervix 15 years ago, Pat since then is okay, but then has positive HPV virus. Please reply to my question for both those cases. Okay, you can see that no suspicion symptoms versus if I have had unexplained symptoms, pain, discomfort from the abdomen, and possibly chronic inflammation. Also, my question specifically in case I go to a clinic, have upper age limit of 44, so have limited time frame. So lots of details.
You don't have an obvious reason of doing hysteroscopy. The main thing is to manage to create some good embryos. I don't know. I mean, in this age group, you could also do PGTA and see that you have managed to create a chromosomically normal embryo. But if you don't do it, at least to see that you have some embryos, because it's not easy in this age group. Now, if you do have a very good quality embryo, it is only one, or you have a chromosomically normal embryo, and you know that it is not easy to achieve that in the age of 43, 44. I mean, this is a very precious embryo. This is a very important embryo. So what I say to women in this age group is that do check. If you only have one embryo and your time is going, and you know that it will not be easy to get it again, well, you don't have anything to lose on checking with a hysteroscopy, even if you don't have a relevant history of recurrent implantation failures or recurrent miscarriages or anything, because you might find something and then regret it. Okay.
Mm-hmm. Yeah. Okay, again, thank you so much. I do hope that it was again helpful. More questions are coming in. Let me just go ahead with the next question from our next patient here. I'm 45 with one failed IVF, have been operated 3 times for fibroids, 2 C-section. My doctor told me I have a scar issue within my uterus. What can be done in my case before going for another IVF?
Where is the scar issues? Is the scar inside the endometrium? I mean, the fibroids were removed with a hysteroscopy or with a laparoscopy. I mean, given of the fact that you had double surgery, you removed fibroids. Sometimes when you remove the fibroids, the cavity is breached. All this might spread an infection inside the cavity. Maybe outside of the cavity fibroids can be combined with some small inside the cavity fibroids, which are not always easy to see with an ultrasound, for example. So, I mean, the first thing in your age is to manage to create some embryos, because it's not easy at all. And if you manage to create some embryos and you haven't recently checked with a hysteroscopy, I mean, I would check. And if there is scar tissue or Asherman's or anything like that inside the endometrium, this needs to be treated surgically. Sometimes it is not easy at all to have results, but you need to try to treat it. If you have a recurrent fibroid or a small fibroid which is submucosal inside the lining of the womb, you need to remove it. If the cavity is clear, the scar tissue inside the muscle of the womb might not be so important, but at least have a diagnostic procedure to show you that we are not missing anything.
Okay. Again, if there's anything else, someone is typing. So if you would like to get some more details, go ahead, type this in. And I will go to question from Juliet. I'm 36, have a low AMH 0.43, will be going for IVF as I've been trying to get pregnant for 2 years, no success, no miscarriages either. Would you say the AMH is the reason why I never got pregnant? And would the hysteroscopy benefit me? Had a spontaneous pregnancy at 31 after the first go.
It's one of the reasons. I mean, in your age, an AMH like that is quite low. If it is associated with a low andral follicular count, this means that the number of the eggs that you will be getting in, even with an IVF, it will be lower. So AMH of 0.43, it means that for your age, you have less eggs than other women in your age. And sometimes, many times, there is no reason for that. Okay, it just happens. If you've been trying for like 2 years, this is a prolonged period of trying. So you need to go to the next step. And the next step with this AMH is actually IVF. Because the longer you delay it, the AMH will be going down, the number of the follicles will be going down, the quality of the eggs will be going down, so your chances will be getting less and less. So you need to go to the next stage. First of all, get some eggs. The good thing is that you are 36, so even a smaller number of eggs can get you pregnant. Okay. How many eggs you will get, it depends on how many follicles you have in your ovaries. And the more you get, the better. So create some good embryos, and then hysteroscopy. I mean, it's not obligatory or necessary for you, but it depends on if your doctor sees something at the time of,
Right.
the IVF, if the lining of the womb will be okay, if it will have normal thickness, etc.
Yeah. Okay. I hope that helped, Julia. Thank you so much. So, and let me have a look. More questions are here. I have stage 4 endometriosis, stuck uterus to the bowel, but no symptom at all. Endometrium biopsy showed normal NK cell types and activity. Normal Th1, Th2 ratio. Blood test showed slightly low red cell number. Do I need steroid? And will steroid cause defects in babies?
The way that I hear the story, not really, since you have done all this testing and since you have done it with an endometrial biopsy, generally, no, they don't cause defects, the steroids.
Mhm. Okay. Okay, I think that's it for this one. Let me just show you the next question, sorry, from our next patient here. I'm 49, no previous pregnancy, no previous fertility treatment. I'm doing fertility test for the first time. Ultrasound showed 4 fibroids. I became claustrophobic with the MRI. I am seeking to do IVF with own eggs. Is there a benefit for me to do hysteroscopy?
Okay, things first of all are difficult for IVF with own eggs in this age group. I mean, the way that I would go ahead with this is to try to create some good embryos. I don't know if you want to PGTA as well, because most of the times the problem is that you don't find normal chromosomes, and if you don't have normal chromosomes, then you don't have an embryo to transfer. So then you don't go through the procedures of hysteroscopy and everything else. I don't know if you will spend money on that or how you will do it, because if you don't have an embryo, even if you put an embryo that has abnormal chromosomes inside, it will not work. Regarding the fibroids, it depends on the size, it depends on the exact position of them, it depends on if they are protruding inside the endometrium, if they are inside the endometrium or outside or close to the endometrium. I mean, MRI would help to determine exactly the position. If you couldn't do the MRI, I mean, at least you could do a hysteroscopy before you transfer the embryos to ensure that these fibroids are not protruding and they are not going inside the endometrium. Because if they are not going inside the endometrium, they need to be removed. Now, if they are close to the endometrium, it's a very conflicting story and a very, you will hear different things by different doctors. Even the evidence is not conclusive about what exactly you need to do. I mean, we usually remove fibroids that are more than 5 centimeters in size, or fibroids that are mildly changing the cavity. They are very close to the cavity, and especially if we have a failed transfer before. This is what the data says. But you need to balance things. Okay, you need to balance surgery, delay that you will have after that. And right now, time is not your friend. So the first thing that you need to do, instead of delaying with all these things, is to create some embryos.
Yep. Thank you so much again for that advice. And I have we received also the follow-up for the acupuncture question. So we were talking about the acupuncturist. About, do you recommend it from physiotherapist, in the healthcare system, traditional Chinese medicine, or from the fertility clinic? Anything you can advise for this?
Well, I recommend it from someone that is doing that. It, his her job to do acupunctures, has a license for all this, and has worked with fertility protocols as well, and has an experience with fertility. So, I mean, usually in fertility clinics, I mean, as far as regards Georgette with us. She's quite experienced, works specifically with infertile patients. She applies specific protocols. We trust her. She knows her job, and we recommend her because we trust her. But
So definitely someone who has
someone
experience.
who knows and has experience and has a license to practice, yeah.
Of course, definitely. Exactly. Thank you so much indeed for that. And let me show you the next follow-up from our previous question patient as well. The scar tissues are inside the cavity. Yeah, the scar tissues were seen through the hysteroscopy. Uterine lining is very thin. I am considering egg donation. What would be my chance to see if the scar tissue is treated?
Sorry, this is my dog that you can hear. I don't know, he has
You
run.
can. It's okay.
But okay, yes, I mean the scar tissue inside the cavity is called Asserman syndrome. It's not easy. I mean, you need to try to remove it surgically. Okay, many times, even if you try to remove it surgically, it's not possible, and the endometrium is still is not getting thicker, and it has problems. In some cases of persistent Asserman syndrome that has been tried to be treated surgically, and it is not recovering, we use the stem cells as well together with the PRP. All these are so that you can try to achieve some healthy endometrium and some thickness, but it's not an easy situation when you have scar tissue inside the endometrium because of previous surgeries and things like that. But the first thing that you need to do is to try to treat it, because sometimes after a surgical nice procedure, you get to healthy endometrium, and you can get thickness after that, depending on the degree of scar tissue as well. Yeah.
Mhm. Right.
And the last thing, if it is not getting better or anything, in cases like that, sometimes even surrogacy is an option.
Right. Okay. Thank you. If there's anything else, you know what to do. I think we'll be slowly finishing. We're almost up with time, but of course, if there's anything else, you know what to do. You can still ask the questions. Can you just explain, because we also have a follow-up from a previous patient. You mentioned that she's 49, if I remember correctly. That's the patient. So if you can explain how to create those embryos, just so we can clear this up. Let me just double check. Yeah, 49. This is the patient, 49.
You do IVF. You get eggs. If you manage to get some eggs, depending on how many follicles you have, you fertilize them. You leave the embryos to grow to day 5. You might not be able to reach embryos in day 5 because some of them are not good quality in this age, and you might not have day 5 embryos. And then if you have a day 5 embryo, you will need either to PGT-A and find out if it has normal chromosomes inside, to take a biopsy. It's a procedure which is called PGT-A, or you will need to freeze them and grade them, which means that embryologists tell you that they look okay, they look not okay. But in this case, you don't know what they really have inside. Okay, so this is the way you create embryos by doing IVF.
Yep. Thank you for the clarification. I hope that helped again, and it's clear for you right now as well. And I think that we will be finishing, but of course, I do see some thank yous coming up your way, Dr. Harry, as always. You can see this. And of course, as always, let me remind everyone that if you wish to get in touch with Dr. Harry directly, you can do that. You can write to me or to Pelargos Clinic directly, and I'm sure they will be happy to help you out. I do see your questions. This is recorded, and you will have a chance to watch this. It will be available on our website, myivfenses.com, tomorrow, so you can look it up tomorrow, and you will be able to rewatch it. And there are more thank yous. I think we will be finishing for today. Dr. Harry, as always, any final words before we finish for today?
Nothing, Caroline. Thank you for giving me the chance to talk. Thanks for all the questions. I hope that I've helped. I'm very happy that I have seen some of our patients as well being here and asking. I really wish to all of them good luck. I know that they've been through a lot of things and a lot of difficulties. We mainly deal with patients with difficult histories. And for everybody that was here to attend as well, all the best with their treatments. And we will be here to help them with anything that they need anytime.
Definitely. And as always, I want to remind everyone that we will be back with more events. I do see some of your comments. I'm glad to see that you found it useful. And I just want to let you know that tomorrow we will be back with some more events, and tomorrow we will discuss endometrial thickness. So if this is something that you are interested in, you can go to myivfanswers.com website and you will find all of our upcoming events. There's plenty more of events coming up, and there are some coming up events with Dr. Harry as well. So stay tuned as always. And Dr. Harry, as always, thank you so much for joining. It's been great to have you, and have a lovely evening, everyone. Okay, and hope to see you here as well quite soon. Take care. Good night.
Bye.
Bye.